Welcome to today's webinar, brought to you in conjunction with the International Cancer Research Partnership, forming part of the NCRI's virtual events programme, which delivers vital support and ongoing education to the global cancer research community. For further information on our future webinars, please follow the link to the events programme in the Q&A box. We are pleased to have Professor Richard Sullivan from King's College London as our chair for today's session, who will now introduce today's eminent lineup of speakers. Professor Sullivan, over to you.
Wonderful, thank you so much. Well, ladies and gentlemen, a very, very warm welcome indeed. Good morning, good afternoon, good evening, wherever you are in the world joining us. It's a really great pleasure for you to be here at the NCRI International Cancer Research Partnership session we have on addressing disparities in international cancer research. And I can't think of a more fitting subject to address. I'm sure you saw from that previous slide, $8.5 billion a year from 143 organisations. That's a stunning amount of money. And disparities, of course, is one of the great ills that befalls the global community. And it's absolutely delighted to be joined by an extraordinary panel who I'm going to introduce to you as we go along. But just up front to say that the running order really is going to be, first of all, we're going to hear from Sigourney, and then we're going to be followed up by a joint session from Dr. Lofters and Dr. Datta. Thank you all so much for joining us. My name is Richard Sullivan, as you heard, from King's College London. Maybe just a few words of comment before I kick off and a few introductory slides. Please do send in questions and answers, questions as we're going along, and like questions. You'll see the chat box there to be able to do that. I'll collate them together, and then at the end we're going to have a little group discussion between us about the different presentations and the questions that have come down the line. Then we have a Twitter hashtag, so it's hashtag NCRI Virtual. And again, as we go along, if you do have any comments you want to make, please do let us put them into the chat box, because even if they're not questions, they're just comments. I can reflect those back to the speakers at the end when we have our roundup and we talk more informally about the presentations. So with that said, I'm going to kick off with just a few opening slides and comments. And with any luck, you should be able to, any moment now, see my presentation. And I guess my job really before we start is just to frame really the discussion for the remainder of the hour. I think it's first okay, let me say a couple of slides are really on the foreground. Inequalities, as I said before, are probably one of the greatest ills that are before cancer research and generally research across the globe. We know from many pieces of work, from the original work of the Marmot Review through to some eminent books now from people like Joseph Stiglitz, that the price of inequality leads to a divided future. And indeed, we know that inequality actually leads to much poorer cancer outcomes. Thomas Piketty wrote this book not that long ago, Capital in the 21st Century. It focuses very much on income inequality and has quite a few sections on research. And what he said in it was the concentration of wealth will attain extremely high levels incompatible with meritocratic values and the principles of social justice. And if we take that to mean all of the forms of ecosystem, be they research or health, this is a significant problem. And there's no doubt, I'm sure we'll come to it, that COVID-19 is going to make the situation much more difficult as we go forward. When we look at cancer research globally, we'll see most of the agenda is dominated by what we consider to be the technocentric agenda. In other words, this is research looking at pharmaceuticals, technologies like robotics in surgery, high-end work and radiotherapy. But of course, improving outcomes includes improving all forms of cancer research, be they health services research, palliative care, and it really is an end-to-end journey between including pathways and models of care. So what does the evidence say about global cancer disparities? And really I have just three introductory slides. The first is that we know that pharmaceutical research and basic research dominate the global research agenda. By any measure, about 82% of total output, irrespective of income settings, actually is focused on fundamental research and medicines and biomarkers. We're seeing an increasing alignment of both the public and the private agenda. Now, they might consider that to be a good thing, but part of the problem here, of course, is it means there's been a widening disparity between the domains. So when you look at domains like epidemiology, radiation, screening, or even supportive and palliative care, a lot of these research domains are getting crowded out because of the dominance in one or two particular areas. The other thing that we find when we do this kind of work is that high income countries set the global research agenda, and I'm sure this is something we'll come to, which is that many countries have their agendas set essentially from the outside. Part of this is the dominance essentially of money and how funding flows, but it's also about ideas and where people are trained, and also allowing different cultures to drive their own research agendas. There are some challenges. Major powers such as China and India have been increasing their research output stunningly over the last 2 decades. If you look at somewhere like China now, for example, is nearly overtaking the United States of America in certain cancer research domains. But the reality is, I think that the impact of COVID-19 is going to have a really significant impact on many countries in terms of their nascent research programs. And again, when we think about disparities here, we can see a widening of the gaps between the high income and the emerging and low and middle income countries. The other thing is that, finally, really to say, is biopolitics and power frame a lot of our research ecosystems. Work we and others have done over the years has clearly shown that, for example, taking Europe, what drives the highest outputs in terms of research is, of course, your GDP. So right at the top here, we have Italy, Germany, France, and the UK. And at the bottom here, in terms of research outputs, Bulgaria, Slovak Republic, Estonia. Research agendas are very nationalistic, and they're becoming more nationalistic. And actually what we're seeing is a decline for the support of global oncology. And I'm sure many of you watching today will know, of course, that in the United Kingdom, the overseas development aid budget has been slashed from 0.7 to 0.5 of GNI, of our global national income. And that's going to have a huge impact on supporting global health. And indeed, cancer and NCDs will be part of that cut. A lot of research areas are focused really on soft funding. And again, this is something the ICRP database has been marvelous in showing, that a lot of areas still actually do not have long-term sustainable funding. And finally, and I think this will come up again as we go through our speakers, there are very significant gender inequalities. And in some parts of the world, the gender inequalities are really quite stunning, in the sense of women either leading or heading up individual research programs in particular. And this is something I think we'll be able to discuss more of later. So that was really just to give you a frame of the global tectonics that we see. We're seeing, let me just stop sharing here. We see, of course, very, very different ecosystems where you are in the world, but generally speaking, disparities are increasing, and most of the data shows that at the moment. And this is something I'm sure we're going to talk a lot more about over the next hour. So without much ado, it's a huge pleasure to pass on to our next speaker in this session today, and introduce you to Ms. Sigourney, who's the co-founder of Black in Cancer. She's very, very passionate about the role of Black students in STEM subjects. She's already getting a PhD, which I believe she may be nearly finished, actually, looking at developing, I think, therapeutic models for pediatric brain tumours. So Sigourney, wonderful to have you here. Really looking forward to hearing you, and the floor is yours.
Awesome. Thank you so much. And thank you so much to the ICRP and the NCRI for the opportunity to speak today. So I'm going to talk a little bit about my organisation that I co-founded last summer, called Black in Cancer, tell you a little bit about where that came from and what our aims are and what we're planning to do. So Black in Cancer was founded last summer in the midst of what was a large global movement in terms of anti-racist movements. And I actually was spending time online trying to find people who did the same thing as me, were Black cancer researchers, because it was important for me to be able to find my community. So if we move to the next slide. I ended up finding Dr. Henry Henderson, who is my co-founder. He is a postdoc based at Vanderbilt University in the US. And we had quite a big conversation about what it meant to be a Black cancer researcher, and realized that there were two main parts. There was the visibility aspect, the fact that there aren't many out there and we didn't have people to aspire to. But on the flip side, we actually found that most of the time we were the font of knowledge for our own families and our own communities in terms of cancer research, in terms of understanding medicine, and so on and so forth. So we had a big conversation about this and what we could do, and realised that actually we could have an impact with the spaces that we were in. So him being a postdoc, me being a PhD student at Cambridge, and realised that we could make this into something bigger and we could really have a movement on our hands. So if you move to the next slide. So we brought together an organising committee of incredible Black cancer researchers in a range of different fields, from undergraduate all the way up to postdoc and early career researchers. We managed to actually make our committee really diverse in terms of gender, so making sure that we were equally representing both male and female. And it was really fantastic to be able to see Black cancer researchers who looked just like me, but they also had experienced the same things, whether that was a lack of visibility for where they could go or what they were able to do in terms of careers, but also had the same aspect in terms of their families and their own communities in giving that knowledge. So if we move over to the next slide. So when we brought together the organisation, we had these kind of two main aims that separated out. So one was around education and community engagement. So our aims were to educate the Black community about cancer and reduce the stigma around diagnosis. We know that it's so important that communities are informed about cancer because it means that we can get things like earlier diagnosis, and we know that early diagnosis leads to better treatment and an increased chance of survival. But we also wanted to take the time to do things like this to inform the wider community about cancer disparities, because the more that you know is the more that you're able to start to reduce these. So then we also had the flip side with networking and fellowship and building an academic community. So we know that it's really important to have a community that reflects the population. So we wanted to build this cancer research network that reflected the cancer patient population, because in a range of countries globally, Black people are most affected by cancer, or they have worse outcomes. So we wanted to make sure that the research and clinical space reflected the patient community that we were serving. In addition, we wanted to provide this visibility for young Black STEM students and give them mentorship and guidance for them moving up within their fields, so that we could maintain what we call the pipeline. So if we go to the next slide. So we wanted to make sure that community was at the centre of everything that we do, whether that's building the science community, building the advocacy community and medical community, and bringing those all together into what we would call our Black in Cancer community, but also making sure that it wasn't just about us, but to bring in the wider network to be able to support what we were doing. So if we go to the next slide. So to do this, we started off by having a social media week, where it wasn't just about the researchers, but was about the general community too. So we introduced ourselves on Twitter using a bunch of hashtags, had a, why are we in cancer research? Because everybody has their own personal story. A pipeline day talking about careers within cancer research, and then it really moved towards the community. So things like talking about cancer facts, what's real, what's not, answering people's questions that they maybe have never had answered before, in terms of, is standing by a microwave going to cause you cancer? Is me being on my mobile phone going to cause me cancer? And answering the questions that were really important to the community, because we have a real big belief that an informed community is an empowered community, and that they can make their own healthcare decisions. So we talked about disparities, with whether that's in diagnosis, treatment, survival, and then how to take care of yourself in terms of decreasing your cancer risk. And then talked about how we could highlight Black cancer researchers, what they're doing, but also pay homage to those who have gone in the past, and to immortalise the legacy of Henrietta Lacks, who we all know had an incredible impact on not only cancer research, but human research worldwide. So if we move to the next slide. So that week kind of went beyond the numbers. We had 80.5 million impressions on Twitter, but it wasn't about the numbers. It was about what we could do for the community. We managed to connect future investigators and collaborators to provide a resource for what we call all of cancer. So that community aspect. So advocates, researchers, and survivors and patients. But also to continue to spark this conversation. We know so often that conversations about disparities and race can often be peaked at a particular time, but can so often die away. So we wanted to maintain the conversation moving forward. And we had all of these different people talk about the impact that that week had had, whether that was them seeing people who look like themselves in terms of being a student, or whether that was how people could engage Black patients or survivors or just their own families, encouraging people to take part in clinical trials, and also people from outside of the Black community being able to talk about their experiences and how the research population and the clinical population reflecting themselves really helped patients to be able to have better outcomes. So if we go to the next slide. So I talked about how we had this kind of education and community engagement and this professional networking and development side and fellowship side. So what we did from that was build these two initiatives. So one is known as the Cancer Awareness Project and the other one is the Black in Cancer Pipeline Programme. So we go to the next slide. So the Cancer Awareness Project is around engaging the community in understanding cancer. So having events around with oncologists, researchers, advocates, for people to really understand more about cancer. Globally, there's higher death rates in people from the Black community with cancer, whether that's in the US or the UK. For example, Black men are twice as likely to die of prostate cancer, even when diagnosed at the same time. Black women are 3 times more likely to die of triple-negative breast cancer, even if diagnosed at the same stage. So we know that there are things other than biology involved, but we want to make sure that the community is empowered and informed so that they can best advocate for themselves in the clinic. We wanted to have initiatives on reducing cancer risk, so dietary advice, physical education, and we actually have a project in the summer coming up in collaboration with the FDA to bring together National Black Family Cancer Awareness Week, which will be events throughout a whole week to encourage people to talk about cancer, to talk about their family histories and a range of things to really make sure that people understand symptoms around cancer, diagnosis, why they should get involved in clinical trials and the impact that that can have moving forward. If we go to the next slide. But in addition, we have this Black in Cancer Pipeline Programme. We didn't want to just target from undergraduate and beyond, because we know so often so many people are lost before then. So we wanted to make sure that we could support Black STEM students all the way through. So all the way from kindergarten, doing Ask the Scientist sessions, career talks, and mentoring students to undergraduate and beyond. So having professional development networks, research seminars to really support those students all the way through. So if we go to the next slide. The way that we're doing this is through really proactive methods. So whether that's, we have an inaugural Black in Cancer Postdoc Award, which is an award for a Black student anywhere in the world who is doing a postdoc, who they will get $75,000 a year for 3 years. And then if they decide to transition to faculty, then they'll get $100,000 to start their own lab. We're part of the OncoAlert Alliance, bringing together large groups of cancer researchers, advocates across the world to really push forward cancer research in whichever ways that we can. We're here with the ICRP. We had a piece in AACR talking about Black in Cancer Week and how we can move forward, and working with foundations such as the Tiger Lily Foundation to really make sure that we can support Black cancer patients all the way from research all the way through. So if we move to the next slide. So that's kind of a roundup of everything that we're doing and why it's so important to bring Black cancer researchers and make sure that what happening in research is reflective of what's happening in the clinic. We so often know that when we take information from people, we're most likely to take it from those who look like us. And whether that is acceptable or not, it is a fact. So what we've done is try to create an organization that allows Black researchers to speak to patients, so that those patients can have that visibility, connect them with Black physicians to be able to understand their own cancer and really feel informed about how they move forwards. And that's from me.
Sigourney, thank you so much. That was an absolutely wonderful presentation. I'm so pleased you mentioned Henrietta Lacks as well. It's an extraordinary story. I think we can probably talk about it later. African-American woman in the early 1950s. But thank you, that's a fantastic. We've already got lots of questions coming in. Please keep them coming and we'll collate those together. But thank you so much, really super. Great way to kick off. It's a great presentation. Pleasure to introduce our next two presenters. And the first presenter is going to be Dr. Aisha Lofters, who holds the Chair in Implementation Science at the Women's College Hospital in Toronto. Has done a huge amount in the field of health equity in her research program, focusing mainly on cancer screening and prevention interventions, but also particularly on barriers to diagnosis for women who experience social marginalisation. And she's going to be joined as well by Dr. Geetanjali Datta, who comes to us from the Cedars Sinai Cancer Research Center for Health Equity in the USA. And again, his work focuses on social determinants and inequalities across the field of cancer prevention, and examining both at the individual and the macro level. So Dr. Lofters, Dr. Datta, thank you so much again for joining us today, and the floor is yours.
Thank you very much. Actually, this is Dr. Datta. I will set Dr. Lofters up for her presentation today. Thank you to the ICRP and the NCRI for the opportunity to speak today. As Richard said, we will be speaking about patient-centered approaches to removing barriers to cancer screening and transforming race-based health research. So cervical cancer is in many respects a cancer prevention success story. Not only are there efficacious screening modalities, there are also effective vaccines for primary prevention. And the cancer community has progressed to the point where the WHO has developed a strategy to actually eliminate cervical cancer globally. The proposed strategy has 3 pillars. The first focuses on a goal of vaccinating 90% of girls. The second focuses on the goal of screening 70% of women between the ages of 35 and 45. And the third is to provide treatment for 90% of women diagnosed with cervical disease. And here we can see the incidence rates of cervical cancer globally. In the light pink, that indicates incidence of less than 7.3 per 100,000, and the darker sort of magenta color represents an incidence of over 26 per 100,000. While these illustrations might lead us to believe that high resource settings will not have to engage in additional efforts towards the elimination of cervical cancer, we would indeed be mistaken. So while for high-income countries, the target would seem to be within reach, cervical cancer is increasingly concentrated in socially marginalized groups in those settings and will require additional efforts and investment. And I'd now like to turn the podium over to Dr. Lofters, who will speak about her work in Canada.
Thank you, Dr. Datta. So the cervical cancer incidence in Canada right now is 8.3 per 100,000, so quite low, but it's still double that WHO goal of 4 per 100,000 that will qualify as a definition of elimination. And I think what we really want to highlight here is that in the era now of HPV vaccines, it's really cervical cancer screening that's going to be that important determinant of inequalities in cervical cancer between sociodemographic groups. So I just wanted to quickly highlight some research that I did a few years ago that was looking specifically in the province of Ontario, which is Canada's largest province of about 13 million people, and very ethno-racially diverse. So about 50% of people are not white, and about 25% are foreign born. So we essentially segmented the population of women eligible for cervical cancer screening using administrative data. And I'd really just want to highlight here this gap where we're looking here at all the women involved in the study were eligible for screening. So they all met the age criteria, met the screening criteria. But if we look at women who were born in Canada, who were less than 50 years of age, living in the highest income neighborhoods and not in a primary care enrollment model. Very quickly, primary care in Canada is structured as such so that some people are formally enrolled, they sign a form with their primary care provider, and every year their provider will get a list of who's up to date on screening, who's had their flu shots, etc. So people who are in that primary care enrollment model, when we look at all of those criteria, you see almost 80% of women are up to date on cervical cancer screening. So actually still quite far from 100, but pretty good with almost 80%. But then if we look at women who were born in South Asian countries, so this is going to be India, Pakistan, Bangladesh, Sri Lanka, who were over 50 but still qualified for screening, living in the lowest income neighborhoods and not in a primary care enrollment model, so more likely to be seeing doctors in a walk-in setting, 22% up to date on cervical cancer screening. So this is the gap that we're dealing with in Canada. When we're talking about eliminating cervical cancer, it's really about addressing the inequalities that are unmasked here in this graph. So what are the barriers to cervical cancer screening for South Asian women in Ontario? There's quite a bit of literature that looks at this. At the individual level, it can be a history of trauma. Certainly the PAP test is not, it's a pretty intimate test. There can be cultural concerns and cultural barriers. There is sexual stigma involved because of the fact that cervical cancer is caused by HPV. And then even understanding, what does the word screening mean? What is a cervix? What is cervical screening all about? We often, though, tend to focus on individual level barriers when it comes to disparities. And I think it's really important to highlight that there are disparities at other levels as well. So there's the test itself, which is an intimate, very personal test, and it is not comfortable. There are provider and practice level barriers. So getting access to an appointment can be a huge challenge. At the provider level, understanding what does cervical screening mean, who is eligible for it. Providing safe spaces. So do we provide, providers, do we provide a space where people feel comfortable coming to visit, talking about personal issues, and having a test like the PAP test? And then that patient-provider relationship is huge. So, you know, whenever we look at ways to increase cancer screening, the trust with your family physician or your GP always comes up. So what are we doing to establish that trust? And then, of course, at the system level, competing life priorities, if people are dealing with income insecurity, food insecurity, housing issues, how important really is cancer screening? How important should it be when they're dealing with those day-to-day issues? Next slide. So there's a very exciting potential patient-oriented approach that's come up when it comes to cervical cancer screening, and that's that of HPV self-sampling. So essentially a woman able to sample for herself, take a sample from the cervix or vagina, and have that tested for HPV. And clinician sampled and patient sampled HPV testing have been extensively studied and actually have similar performance characteristics. And in countries like the Netherlands, it's being used in some organized screening programs. Other countries like Guatemala, I know, have used this as part of their central organized screening programs. And it really can be a way of promoting female empowerment and addressing many of those barriers that I just talked about. So we really wanted to understand, is this acceptable among the underscreened in Canada? And if so, how best should it be implemented? I just want to highlight too that WHO has recognized the importance of HPV self-sampling and its potential role in eliminating cervical cancer. As you can see in the bottom left, it is easy, it's painless, can be much more convenient, can be cheap, and can be done privately. I just wanted to, if you could go back one slide, highlight some work that was done there's a region of Ontario called Peel Region, which actually has the highest density of South Asian immigrants in Ontario, and I would probably bet in Canada as well. And we did some community work here, and this is just the cover page of our community report that we called Making It Happen Together, because we really wanted to understand from the community perspective, what can we do to increase cancer screening rates? So we worked with South Asian primary care providers, but also healthcare organizations, community advocates, community service organizations to really understand from the community perspective, what can we do to increase cancer screening rates? And some of the key points that came out there were, first of all, the importance of education, awareness, and empowerment, similarly to what Sigourney Bell had mentioned in her conversation, and also just the idea of really being community-based and community-rooted. Now, when we come back to this list of barriers, we can see that HPV self-sampling really does check a lot of the boxes. It doesn't check all of them, but if you think about, sexual stigma, history of trauma, the test itself, getting an appointment, HPV self-sampling does have the potential to address a lot of those barriers. Next slide. So we did some qualitative research using both surveys with open-ended questions, focus groups, interviews to understand women's perspectives and how they would feel about HPV self-sampling. So I just wanted to highlight some quotes from that work here. So one example, I think this way is better than the old way because some women like me are very shy and they prefer to do it themselves if they know how. Or yes, for sure, it would be more convenient and more comfortable, so I can do it more often and more regularly. But this third quote does highlight there's never one solution that's going to solve all problems. So the sample taken will be by a professional who knows his job versus myself, who was unable to get the proper picture of what and where I should collect the sample from. So just highlighting that for some women, the idea of doing it themselves, brings concern about, am I doing it properly? Is this going to be an appropriate sample? Next slide. So there's some ongoing research that we're doing right now, working with a community champion who herself is a South Asian woman. She was trained as a pharmacist back home, is not practicing as such in Canada. That's a whole other conversation. But she is our community champion, and she's helping us to recruit under or never screened South Asian women in the Greater Toronto area. And women are really self-selecting based on their opinion about whether or not they want to try the self-sampling kit or not. And so far, we've had about 2/3 who do want to try it and about 1/3 who don't. And then all participants complete a questionnaire with her about their knowledge, their attitudes, their practices around screening, and their thoughts on self-sampling. And next slide. So both groups were following up with them, getting feedback either about their experience using the kit or their decisions around going on to get a pap test if they chose to do so in the other group. And of the 70 so far that have reached a kit, 54 of them have followed through and completed the kit, and we continue to follow up with the rest. I do want to highlight, and I bolded it and italicized it here, the importance of multiple touch points with the community champion. So it's not a quick 2-minute conversation and she moves on. She's meeting with people at community events, at religious institutions, at before COVID, community teas, and talking to people and finding that it needs to be, sometimes they are willing to hear a little bit, but then they want to step away and think about it and come back. They might ask her a few questions, and then often after multiple touch points and establishing that relationship, then they're willing to try it and learn more about screening. Next slide. So self-sampling really has been acceptable to many of these women, giving them a chance to be screened that they may not have otherwise had. I should say everybody involved is somebody who is considered either under-screened, so overdue, or has never been screened. When we talk to women about why they've not been screened in the past, some things that jump out are fear of the test itself, fear of what it means if there's an abnormal result, fear of what people will think if they do the test, and then other things is lack. So lack of a physician, lack of time, and then lack of knowledge. But self-sampling does give an opportunity to move beyond some of these barriers and get screened in a safe, comfortable way. And I said most women we've followed up with do prefer the kit over a pap test. So just some reflections to end my section before I pass it back to Dr. Datta. It's so important to start with the patient and the community voice, because they are the experts on themselves, right? They are the ones with the lived experience, and it doesn't make sense for us to be behind closed doors trying to solve problems without speaking to the people whose problems we're trying to solve and letting them lead that problem solving work. There have to be multifaceted, multi-level, multi-targeted approaches. It's not one size is not going to fit all for something as complex as cancer screening, cancer treatment, etc. I always think of the analogy that we use the word cancer, but there's so many different types of cancers and so many different types of cancer treatments, and the same thing has to happen with addressing disparities. And really just to highlight too, that we really have to explicitly describe ethno-racial disparities. We also have to understand the mechanisms behind them, and also in order to be able to appropriately address them. And I will pass it back over to Dr. Datta.
Thank you very much, Dr. Lofters. I will now be switching gears a little bit, but as you will see, not necessarily entirely, to discuss transforming race-based health research in Canada specifically, but it has bearing for the international research community as well. So this portion of the talk is based on a commentary that Dr. Lofters and I published earlier this year along with one of our colleagues, Dr. Siddiqui. While these comments came out of discussions around COVID-19 and the crisis surrounding that, they have bearing for health research more broadly, including cancer research. So the global pandemic has affected everyone. However, in Canada, racial and ethnic minority groups have suffered a disproportionate burden related to incidence and mortality. And here in this figure, we see that mortality rates are higher in neighborhoods with a higher concentration of visible minorities than in neighborhoods with lower concentrations of visible minorities. I will point out that these data are measured at the neighborhood level and not at the individual level, and this reflects the current lack of research infrastructure in Canada to study race-based health differences. So we'll go through a series of headlines that will illustrate some of the issues around this and the COVID-19 crisis in Canada. From the beginning of the pandemic, troubling patterns were observed anecdotally in Canada, and some called for disaggregating statistics by race in order to document disparities. However, given that statistics are not routinely disaggregated by race or ethnicity in Canada, there was some resistance to do so. So here we see a month into the pandemic, officials did not feel providing those statistics were necessary. That continued for several months. Here is a headline from May. And here again in July, as data was being collected on some demographic characteristics on people who tested positive for COVID, we asked the question, why was there hesitation to do so for race and ethnicity? So in part, that's reflected in this headline. The hesitation in part came from a fear of an inadvertent legitimization of biological conceptualizations of race and increasing medical prejudice and stigma in the population more broadly. So these fears stem from some existing structural, from the existing structural racism embedded in Canadian society. So here's a definition of structural racism. Structural racism is the totality of ways in which societies foster racial discrimination via mutually reinforcing inequitable systems, for example, in housing, education, employment, earnings, benefits, credit, media, healthcare, criminal justice, etc., that in turn reinforce discriminatory beliefs, values, and distribution of resources. So given Canada's reputation for being an inclusive society, we might question if this is actually an issue in that context. Well, a 2017 report of the United Nations Working Group of Experts on People of African Descent on its mission to Canada expressed that they did indeed think it was an issue. So here's a quote from that report in which they state, anti-Black racism and racial stereotypes are so deeply entrenched in institutions, policies, and practices that its institutional and systemic forms are either functionally normalized or rendered invisible, especially to the dominant group. Here is another quote, and it's from the Canadian Public Health Association policy statement on racism and health. And in that policy statement, they acknowledge their own role in perpetuating structural racism. And they additionally state, anti-Black racism is ubiquitous in many Canadian institutions and is responsible for perpetuating contemporary Black poverty and unemployment, racial profiling, law enforcement violence, incarceration, immigration detention, deportation, exploitative migrant labor practices, disproportionate child removal, and low graduation rates. So these are all pretty damning. So given this, we recommended establishing an Institute of Racism and Health within the Canadian Institutes of Health Research. It's important to name racism as a determinant of health and as a determinant of health disparities, and not to assume that only immigrants suffer bias within Canadian society. So we make these suggestions because it's not enough to just collect and report data disaggregated on race. It's important to facilitate careful interpretation, and provide research infrastructure to study the impacts of racism and anti-racism interventions. So how would an Institute on Racism and Health fit into the existing institute system? Here's a list of the current CHR Institute. There are currently 13 institutes, including institutes that address specific populations, such as the Institute of Gender and Health and Institutes of Indigenous Peoples Health. So these institutes benefit from the development of strategic plans and goals, advisory groups, and developing trainings for the research community more broadly. We feel that this would be an important step in addressing race-based disparities. So here's another quote, this time from March 11th, 2021. And it sort of illustrates the fact that we acknowledge that change will take time. So for example, still a year into the pandemic, race-based data are being requested. However, even though it will be an investment to make these changes, we believe it is worth it. And here's just a list of references from both of us. Thank you very much.
That's absolutely wonderful. Thank you so much. There are so many questions coming in. It's absolutely incredible. What I could do, maybe invite Sigourney as well to turn on her camera, and we'll stop sharing these slides if that's okay, and then we'll bring you all together. And I guess I'm going to start with I'm going to dive straight in actually and pull a few of these questions together and address it through one single statement here. And I wouldn't mind your reflections from all three of you. And that goes back to the point you made to me about, is race important when we're talking about research here? And I want to think to answer it both in terms of race as being an important determinant of being a successful researcher, and also as someone who wants to describe me, the actual impact on the research community and the participation. And I think Dr. Lofters, you mentioned about sort of ethno-racial disparities, needing to be able to describe them, understand them before you address them. And so I'd like to unpack this whole thing. Do you think we have a problem at the moment? Is race important in cancer research, and do we have a problem? Who would like to start? Sigourney?
Sure, I'll start. Yes, it is an issue. From the very point that we have disparities, there's a clear problem when it comes to people being treated equally, whether that's from the research aspect, whether that's from the clinical trials aspect, or whether that's just generally being treated, by a physician or a clinician. There's clearly something in the pipeline that doesn't work, because why people from certain ethnic backgrounds are more likely to die of their cancer, even the fact that we don't have the information as to whether that's because of biology or not is still a racial issue, or still a disparity that needs to be talked about. Additionally, in terms of diagnosis and things, within the UK, ethnic minorities have to go to their general practitioner 3 times more to be able to be referred to a specialist. Clearly an issue there. So yeah, I think it plays a role in so many parts, and still even further than that, in having cultural competence within our clinics for people to understand, whether that's people asking about food, for example, like what food can I eat when I am on chemotherapy? Normally I would eat X. Now, if you don't have that cultural competence within the clinic to even know what X, Y, Z food is, or how that might impact on treatment, so on and so forth, it's just having that holistic approach, and you can't unless you consider race as one of those factors, whether it is biologically or not.
Super, thank you very much. Please, Dr. Lofters, Dr. Datta.
Yeah, I totally agree with everything that Sigourney just said. And I think the one thing I'll add too is when we think about representation. So I think that's what's so fabulous about the Black in Cancer Initiative is because, as Sigourney said, it's like looking for somebody who looks like you in this world that you're in. And if we had no issues, then theoretically in any particular jurisdiction, the proportion of Black researchers would be roughly equivalent to the proportion of the Black population. And certainly I can tell you in Canada, that's not the case. In the Greater Toronto area, the Black population is about 10%. And researchers, it's definitely not 10%. So once we acknowledge that representation isn't equal, then it either has to be that we have an issue, we have a serious structural issue, or it has to be that racist views are correct. And if we're not going to go down that path, then we have a serious issue. And I think, to Sigourney's point, it goes all the way back through the pipeline. It all goes all the way back to when a little 4-year-old or 5-year-old is thinking about what they want to do and who they want to be when they grow up, and who do they see in front of them as role models and mentors, and where are they directed to by their teachers.
Yeah, that's an extremely good point about the role models. Dr. Datta.
Yes, I absolutely agree with Dr. Lofters and Sigourney, and I would say also that there certainly is a problem, especially in cancer research, when thinking about race-based inequalities. There is a tendency for the medical establishment to feel comfortable in the idea that there are biologic differences. Mm-hmm. It is a step for them to take to conceive of the structural racism that exists within society and how that impacts cancer. And by the time someone is diagnosed with cancer, they're sort of at the end of this very long pathway that, as we saw from the list that I provided, that starts, at birth and through education and through messaging and systemic sort of biased treatment, throughout the life course. And it's a challenge to change that frame, in the medical establishment and in the research establishment, which is why we recommend framing it in terms of racism, because it sort of really names the underlying problem that we're experiencing at the moment.
So I wonder if I could take that question on and weave in some of the other questions that are coming down on the chat as well. I guess it's the dominance of the research agenda as it stands now. What we're talking about is sort of ethno-racial disparities and research into that and illuminating this in order to get to the solutions. You've got to have a research ecosystem that accepts that sort of research, that funds it. So I guess when we reflect back to you is, do you think we have a research ecosystem that does that? And indeed, maybe taking David Conway's view about the intersectorality here, that maybe it's not just a matter of ethno-racial, it's also a matter of gender and poverty as well. Maybe I'm going to throw that in the mix. And I just wondered, looking at the research ecosystems in your own experience, whether or not you think there's a structural problem within the research ecosystems per se, when you're dealing with this intersectorality, not just ethno-racial, but the other bits of gender as well, and poverty. Sigourney?
Yeah, sure. So yeah, I think that's exactly right. We do have to consider intersectionality in everything. It's something I face as a Black woman in research, and especially even when we look at, talking about the academic environment. I didn't meet a Black female PhD until I'd started my own PhD. That was 9 years after finishing my undergraduate degree. Having worked for 3 different pharmaceutical companies, and that visibility is so important. And it doesn't just impact on me as a researcher, but impacts on the clinic as well. Having those conversations in terms of patients and feeling comfortable and all of those kinds of things. So it definitely plays a part. When we talk about the socioeconomic background part, of course, that has a major issue, or has a major part to play in terms of cancer risk and so on and so forth, for sure. But even when we normalize for that, even when we look at women or men who get cancer from, who aren't from poorer socioeconomic backgrounds, they still have these disparities within their, survival of cancer. So although, yes, that does play a role, and it plays a role in every ethnicity in terms of socioeconomic background, there's still the counter or the additional addition of race as well. So yeah, you're right. They are all compounding factors that lead to even worse outcomes.
Yeah, fantastic. Thank you. Any other comments on that? And particularly, maybe I wouldn't maybe just also segue into another comment here. There's this question as well. So obviously the focus on cancer of the cervix, you're having to deal here with a new programs that are being implemented in countries. You say these really substantial gaps you're already finding here, and maybe I could just ask you to talk a little bit more about whether or not you think is this a technological problem to solve, or is this a cultural problem within research and within the populations and how populations are dealt with? Dr. Datta or Dr. Lofters?
Dr. Lofters,
Sorry.
you want to go first?
I think we're eyeing each other, seeing who's going to speak first.
Yes.
So I think with health equity research, I think it's always about asking the why behind the why. So I think self-sampling could be a very effective method, but we have to remember, why could it be an effective method? And it's because it has the potential to address these barriers. And I think we have to ask, well, why do those barriers exist? So self-sampling could tackle some of those barriers, but ultimately, I think the structures that we have within our societies that create these disparities, that's where the real action needs to happen. And I think when you come to the question about research funding, I think there's so much more work to be done. I think, having explicit funding calls in the cancer research ecosystem that focus on ethno-racial disparities, I think having specific funding support to get more Black researchers and more underrepresented researchers, whether that be based on Indigenous status, gender identity, just to increase that funding pool. I think we have to be very explicit and name it, when we're talking about these funding opportunities. One thing that Dr. Datta and I have discussed a lot is that often when you apply for funding, and if your research does focus on disparities or focus on racism, who's reviewing that? And what qualifications do they have to assess whether or not this research is high quality?
Yeah, it's a huge important point. Please, Dr. Datta.
No, I obviously completely agree with what Dr. Lofters said, and I would just like to explicitly state that I don't think it's a technology problem necessarily. I think that, when we think about sort of the fundamental causes of disease, it goes back to social structures and opportunities and things of that sort. And so we try to solve those problems, downstream by using technology, because these are very neat and clean interventions that we feel comfortable with, that people can make money off of, companies can leverage, the financial ramifications of that. But, a company doesn't necessarily make a lot of money if we provide, universal preschool or kindergarten to children, which, down the line really has shown in many settings to have very, very impactful effects on health down the line, including in cancer, and really help diminish inequalities. And so it's not just a technology problem. We are using technology to help us solve these problems, but I think that we shouldn't. We tend to romanticize the technology in lieu of the more weighty topics around social structures that really underlie the need for the technology.
So let me just push you all a little bit more on this, on the funders, because this is coming across quite a lot in the questions about what people can do, and particularly about what funders can do here. So do you, and this is not a loaded question, well, maybe it is a loaded question, do you feel really that the way that funders currently work, in terms of the constitution of their committees, etc., and the funding calls, are really reflecting what you see as the true societal needs for cancer research? Or do you think we're dealing essentially with Olympic funding committees just funding Olympic athletes with Olympic cost medicines? There we are. Let's put my bias into the conversation. Who would like to kick off with that? We don't have to pick any funders out in particular, obviously. I just want to sort of generally talk about the funding ecosystem. This is about, the International Cancer Research Partnership. What are your views? Who would like to kick off? Dr. Lofters? Oh.
I agree. I do think it's a big issue. I think, one pattern that we see is that people who are successful tend to get funded. So funding kind of begets more funding. But then again, if we think back to the why and the systems and the structures, historically, if you are focused on ethno-racial disparities, if you are coming from the global south, for example, you're just less likely to have that funding. So it's less likely for a funder to trust to give you the funding, and then the cycle continues. The other thing too, that I think is really important, is that I think often this work around disparities, around equity, is considered fluffy. Like, to be frank, it's considered the softer part of the science, and it's considered not as crucial. I've seen this play out in COVID, where when we're thinking about disparities, people always say, well, we've got to get this done urgently, and then we can deal with the disparities. And that approach just leads to the widening of the gap. So I think we have to we need a cultural shift in how across not just cancer research, but research in general, how we view issues of equity and disparities, and recognize that if we're not addressing that, we're lowering the quality of the research that we're doing, as opposed to it being viewed as a softer, fluffier thing to add on if we've got time. So again, I really personally am very much in favor of explicit funding calls that focus on disparities, and explicit funding calls for salary support that want to raise up the profile of underrepresented researchers.
Yeah, no, thank you so much. I know we're drawn to, I mean, we could keep on going. I have so many questions here and so many comments, most of them just saying how wonderful all your talks were. I guess in the last 5 minutes, I want to give you a chance to, I don't know, maybe wave that magic wand, and within this sort of topic of disparities, at whatever level you feel at, what would you, each of you, like to do if you could really change something, one or two things? What would you really like to do? It's always so unfair picking one person to go first because everyone else gets more thinking time. Ms. Bell, Sigourney, can I maybe start with you, please? What would you like to change?
Sure. Oh, it's hard to just pick one thing. As you can tell by the way we ran Black and Cancer, we definitely haven't picked one thing to focus on. But I think in terms of the overall aim is to reduce disparities. That's what we want to do. And if we can do that by being a part of the research to encourage more people to get involved in clinical trials and things, that's really, really important to us. But that has to happen at every stage across the way. And I think, as Dr. Lofters said earlier, it's about that change in culture, but all the way through. So whether that's for funding, whether that's in the clinic, the way that Black patients are treated, how their symptoms are recognised, all of that, if we get that culture shift, it shifts everything the entire way around. But until we do that, we have to work in these small parts in funding research that is for disparities, is around understanding that. But even more so, then what we do with that information, because so often it's, we found out all this information and it's due to this and it's due to this, but what are we doing about that? Right. It's all well and good, just like anything, it's all well and good to make a drug, but unless somebody takes it, it's irrelevant. So it's what we do with that information and pushing that agenda forward.
That's wonderful. Thank you so much. Dr. Lofters?
If I'm going to pick one thing today, I would say representation. So just really making sure that at the end of the day that there's representation across all levels. Even within my institution, when we've been looking lately at this issue, as been mentioned, it's come up so much in the past year, and there's quite good representation of ethnicities when we look at frontline staff. But the higher up you go in the hierarchy, it completely shifts. So I think that's the one thing that I would focus on, is representation across all levels.
Yeah, that's fantastic. Thank you so much. Please, Dr. Datta.
I have the disadvantage because I was going to say representation as well, but I will take the opportunity to go a little bit further. That exactly like Dr. Lofters says, that representation in the decision-making bodies, I think, is really important. But representation not only sort of in racial, ethnic minorities or gender groups, but also socioeconomic groups, disciplinary diversity, I think, is very important. I also think that we tend to think of this very top-down, and that if we could integrate the community voices into what we're thinking, we think we know what's important and what's really driving some of these things. We don't have all the answers. We're embedded in our communities, and I think those voices need to be heard too and be part of the decision making about who is funded and why. So I think that representation, yes, is very important. By getting more minds and voices around the table, it would be very useful.
It's wonderful. It's amazing when you blink and it's suddenly all over, and it's been an extraordinary and wonderful panel. This is probably, I would argue, probably the most important panel I've done for a long, long time. I just want to thank all three of you for your time and your insights. It's superb. I'm going to be personally sending out the video recording of this to every funder I possibly know, because they need to listen to all three of you and take note of this. So I want to just thank you for your time, and also for your efforts and your advocacy in this area as well. It is, this is about representation. It's also about advocacy and role models. Huge important. I know Sigourney mentioned that earlier. So thank you all three of you very much indeed. A very big thank you as well to Lynn Davies, who's been working tirelessly behind the scenes on the International Cancer Research Partnership since I certainly knew her from the Cancer Research Campaign days. It's a wonderful initiative, and it helps illuminate these disparities as well. That's what you need. Also to Amrit Ranger and her colleagues as well for organising this. It's been stunning. I know how much work she's put into this, and they're always quiet. It goes smoothly because of all the pre-hard work. So Amrit, thank you so much for all your hard work on that, and also to thank all of you for joining us today. Please do listen at this again when it's been recorded, because you'll always pick up new things when you hear it again. I think there's going to be a survey posted, which will be, the link is in the Q&A session, so please do fill that in. And also have a look at the NCRI website, because there's a full virtual series program. We definitely do 3 of you on again for another massive session on this, because I'm sorry, we probably got through about a quarter, if that, of all the questions. So we definitely want you all on again. Thank you all very much indeed. Thank you all as well for joining us today to listen to this, and let's go forward and make the world a less unequal place. Thank you so much.